In this slide, we observe a patient with Parkinson's disease with a classical clinical presentation, rigidity, tremor, and bradykinesia. The diagnosis of Parkinson's and Alzheimer's can be very difficult in the clinical scenario, since there are many neurodegenerative diseases with overlapping signs and symptoms. With this in mind, we propose an auxiliary testing, using immunohistochemistry to detect levels of tau and alpha-synuclein proteins in skin obtained through punch biopsy. These proteins undergo misfolding and accumulates as abnormal deposits in the brain of Alzheimer's and Parkinson's disease patients. The materials we use to perform this procedure are listed in this slide: sterile gauze, sterile gloves, 1 cc syringe, 27 gauge needle, 2% lidocaine with epinephrine, 40 millimeters biopsy punch, iodine solution, benzoate solution, 1 centimeter sterile gauze, and transport tape. After donning the sterile gloves, we clean the overlying skin with an appropriate disinfectant. In this case, we use iodine solution. We apply the disinfectant in a widening concentric circle to the outer limits of the preauricular area. We achieve local anesthesia of the preauricular area, infiltrating subcutaneous 0.5 cc of lidocaine with epinephrine. It is important to leave a little bump in the skin. The punch biopsy instrument is held in a 90-degree angle over the skin and rotated downward using a trolley motion created by the first 2 fingers of the dominant hand. Then, we retrieve the biopsy, making a smooth movement of the instrument in a 4-directional cardinal point to separate the specimen from the subcutaneous tissue. After that, we apply gentle pressure to achieve hemostasis. Here we apply benzoate solution in a widening concentric circle to obtain a more adherent surface in order to add a transport tape that will permit the closure of the wound nicely. We have frozen one of the samples for storage. The other one is preserved in a paraformaldehyde for its preparation and histological analysis under light microscopy. The skin biopsies are included in paraffin wax blocks prior to microtomy. Here we can observe how we use an ice cube to get the cold paraffin wax block, which in turn will permit a smoother slice of the block. Here, we transfer the section of interest into a water bath. The sections are mounted from the water bath into the final slide. For epitope recovery, slides were submerged in a Diva decloaker solution and placed in a pressure heater during 30 minutes, followed by a 20-minute cooling time at room temperature. The enzymatic blockade and the addition of a primary and secondary antibodies involve several incubation lapses that will require up to 8 hours of work. Here we observe the aminoethyl carbazole preparation. The solution will interact with the specific peroxidase from the secondary antibodies. It is important to note the transparent appearance of the aminoethyl carbazole solution. It will only develop a red brick-like color when precipitates over the slides, only in the sites where the protein of interest is present. Under the microscope, we expose the slides to aminoethyl carbazole around 12 to 14 seconds in order to avoid the development of a non-specific red noise background in the tissue. For a more precise assessment of the morphology of the epidermis, the nuclei of the keratinocytes were contrastained with a hematoxylin. This will appear as a blue-violet color circles. Finally, a aqueous glycerol gelatin mounted medium is employed to fix the slide. This will allow to preserve the slide to further histological analysis under the microscope. In the skin biopsies, we mainly studied 3 proteins: tau, the normal protein called PHF, hyperphosphorylated tau, abnormal AT8, and alpha-synuclein for Parkinson's disease. This is what we have found. In these pictures, we observe the normal tau protein present in the skin. As we can see, there is no difference between the healthy patient on the left side and the patient with Alzheimer's disease on the right side. In these slides, we measured the abnormal tau protein detected by the specific AT8 antibody. This is the same protein found in brains of patients with Alzheimer's disease and some patients with Parkinson's disease. The healthy patient is on the left side of the screen, which doesn't show any red spots, which means no expression of abnormal tau protein. However, in the right side image of a patient with Alzheimer's disease, we can see several red spots in the epidermis. This indicates a strong presence of abnormal tau protein. In these pictures, we can observe immunofluorescence staining. In the upper image, we show the appearance of a healthy patient in blue color PHF, their normal tau protein. In green, the abnormal 88 isoform, and in red, their normal nuclei. When we merge the three stainings, we can clearly observe that the patient with Alzheimer's disease has a higher proportion of normal 88 isoform, shown as green positivity. In Parkinson's disease, the main pathological protein is the alpha-synuclein. In this slide, the healthy patient is located on the left side of the screen, which doesn't show any positivity for this protein. But when we compare it to a patient with Parkinson's disease, which is located on the right side of the screen, shows several red cells indicating positivity for alpha-synuclein.